Hello, dear friends. My name is Arun Sanyal, and it is a pleasure to talk to you today about the management of non-alcoholic fatty liver disease in 2022. Here are my conflicts of interest. I think the first and probably the most important thing to remember is that non-alcoholic fatty liver disease is not an isolated liver disease. It is part of a multi-system disorder. And when the liver is affected, many patients also have other end organ diseases, and we recognize these as risk factors for fatty liver disease in the form of obesity, hypertension, dyslipidemia, type 2 diabetes, which are the common features of metabolic syndrome and are associated with arterial disease, diastolic dysfunction, type 2 diabetes, and chronic kidney disease. So what connects all of these different end organ diseases is underlying metabolic stress, which leads to systemic inflammation and fibrosis. That in turn affects each end organ somewhat differently. And the root cause of this is frequently diet-induced obesity or increased visceral adipose tissue. Now, there are already a lot of work going on with respect to these different end organs. And each of these end organ diseases represents a competing threat to life. So in the context of patients with fatty liver disease, it is important to remember that the heart, the arteries, the kidneys, all are competing risks for death. And there's no point fixing the liver if the person is going to die from something else. So it is important to focus on improving arterial health with blood pressure control, correction of atherogenic risk, reducing vascular inflammation, improvement of diastolic dysfunction, keeping an eye on the QTC to prevent arrhythmias, preserve beta cells, and to stabilize GFR. And from a liver point of view, to reduce cirrhosis and thus decompensation, and to prevent hepatocellular carcinoma. So let us first then start thinking about how we manage this. And in order to address all of these different end organs, we must consider the root cause. So starting with this, let's first think about the management of the systemic milieu in which the NASH develops. Now, in the following slide, you see a heat map of caloric consumption in many parts of the world and the prevalence of fatty liver disease shown in numbers in these different regions. And as you can see, even in a country like Chile, there are many patients who are consistently consuming well over 3,000 calories per day, and they may not be burning 3,000 calories per day. So when you have an excess of calories, regardless of whether it comes in the form of sugar, fat, in the end, you store all this excess calories in the form of fat. And that leads to adiposity, which in turn leads to insulin resistance and everything else that follows. Now we talk a lot about lifestyle, but we don't spend enough time understanding why lifestyle fails in most patients. And in order to be successful with lifestyle intervention, you have to obtain a good social history, a family history. You have to understand the behavioral underpinning of why people eat and live the way they do. What are the clinical issues that affect their behavior, such as post-traumatic stress, which can make you eat in some people, and depression, anxiety, eating disorders, addictions, and all of these impact feasibility for change. So if you want to be successful with lifestyle intervention, it takes time and it takes professional people to go through this in a systematic way. So you develop a personalized option for the individual patient. And the problem is that most of us as busy hepatologists do not have the time to do this. And that is why lifestyle intervention fails in so many patients. So if you're serious about managing fatty liver disease, serious about managing metabolic health, you need to integrate a dietitian and a clinical psychologist to the care team. Now you'll say, well, I could just do bariatric surgery. And there is no question that bariatric surgery makes you lose weight, improves cardiovascular outcome, potentially even improves liver outcomes. There's some data from Cleveland Clinic suggesting that. But this has to be also weighed in the context of its risks. And there is no question, as shown in this meta-analysis, that there are risks. And an emerging risk that we are just learning about is an increase in suicide risk after bariatric surgery. There's also an increased risk of alcohol consumption after bariatric surgery. So if you take away food addictions and do not find proper replacement, it can turn into alcohol, it can turn into other drugs and other problems. So we really need to pay attention to this. So bariatrics is a very powerful option, but it is not an option for everybody. It is a treatment, it is not the treatment. Now, for a more practical purpose, what has really emerged is pharmacological therapy. And the lead candidate here are the GLP-1s. And GLP-1s, as you know, are cardioprotective, induce natriuresis, reduce blood pressure, reduce body weight, reduce fat. And from a NASH perspective, reduce triglyceride storage, inflammation, etc. So in a phase 2 study, what we showed was that up to 59% of patients getting 0.4 milligrams of semaglutide actually had NASH resolution. But unfortunately, as shown on the right, this did not translate into an immediately obvious improvement in fibrosis. Now, with fibrosis improvement, you have to remember that it is not the regression, but it is really the progression of fibrosis that determines who is going to get to cirrhosis and then have a clinical outcome. So it is much more clinically relevant whether you are actually having an improvement in the proportion of people having fibrosis progression. So we looked at fibrosis progression, no change, and regression across the various treatment arms. And what I want you to focus on this slide is the pink wedge absolutely on the right, where you look at the placebo arm and you see that the numbers are about 18%. Now, if you go all the way to the left, and then you work your way from left to right, you'll see that with increasing semaglutide, there is a dose-dependent reduction in the proportion of people who had progressive fibrosis, suggesting that the improvement in NASH was indeed being translated into reduced fibrosis. Now, there's a phase 3 trial going on globally, and hopefully this will again confirm this, or at least show that we are actually slowing down and reducing progression to cirrhosis. So, but that remains to be shown. We also know that GLP-1s reduce all-cause mortality, hospitalization for heart failure, and improve renal status in patients with type 2 diabetes. So this is a leading class of molecules that provides help for all the end organs that are affected. Similarly, SGLT2 inhibitors improve multiple outcomes, such as heart failure, MACE, and worsening of chronic kidney disease. It is important to address atherogenic dyslipidemia in NASH, and it's very important to remember that statins are safe to use and reduce LDL cholesterol, but they do not impact small dense LDL. So what is small dense LDL? So normally when your liver makes a small amount of triglyceride, you make small VLDL particles. These are cleaved by lipoprotein lipase, and the triglyceride is removed, resulting in intermediate density lipoproteins, which are then converted into low density lipoproteins. Now, when you have a lot of triglyceride being produced in NASH, the VLDL particles are much bigger. The lipoprotein lipase cannot get rid of all the triglyceride. So the intermediate density lipoproteins have more triglyceride than they should, and this renders it susceptible to hepatic lipases. So for the same amount of cholesterol, you cleave the LDL particle into many smaller LDL particles, which are heavier. And thus these are called small dense LDL particles. And because they are smaller, they can penetrate the endothelium more easily. They have more surface area because there's more particles, and they get oxidized and be more pro-inflammatory. And in addition to that, in patients with NASH, there's reduced LDL receptor expression. So statins are really important because they improve LDL receptor expression and can bring the LDL cholesterol down, but they do not impact small dense LDL, for which the patient has to engage in exercise because that is one of the most powerful ways of reducing small dense LDL. So let's summarize what we learned. That is, to reduce, patients need to engage in weight loss. We talked about how to engage in behavior, the use of antihypertensive drugs, use of statins, treatment of dyslipidemia, smoking cessation, weight loss. And we assume that this is a population that is not consuming significant amounts of alcohol. So it is non-alcoholic disease that we're talking about. And then, of course, there are treatments for type 2 diabetes and treatments to slow down the worsening of chronic kidney disease. Now, let's focus on the liver. Now, from a liver point perspective, it is really the progression to cirrhosis that is the most important endpoint. But once you get to cirrhosis, that's when you start getting clinical outcomes. And we showed this in a New England Journal paper just a few months ago. And given the numbers, and we expect these numbers to go up by 2 to 3-fold by 2030, you can't fix this with just transplantation, because we only do about 8,500 to 9,000 transplants annually. So there are far more people who have this disease. So the expectation of any effective therapy is to slow down or reverse progression of cirrhosis. And of course, in the short term, you get most confidence that you are slowing down this fibrosis progression by demonstrating regression of fibrosis, which is why that's what the regulators look for. So our goal is to stop this progression to cirrhosis. Once again, reiterating, it is really the reduced progression that is most important, but we like to see regression because that gives us more confidence that you are indeed slowing down progression to cirrhosis. So how do you first assess who to treat? And that is really based on, your degree of fibrosis that you already have. Now, histologic assessment was the classical reference standard, but in real world, very few people use histology. There's now a lot of data showing that FIB4 actually is a very good tool for this purpose. If your FIB4 is less than 1.3, your likelihood of a liver outcome over the next 5 years is very, very low, almost zero. And then if your FIB4 is over 2.67, you're most likely to have a liver outcome about within the next 5 years. And if you're in the middle, then your risk sort of falls also in the middle. And so for particularly, once you've done your FIB4, if you do a secondary test such as FibroScan or the ELF, which has now been approved as a prognostic biomarker, then you can identify the population that is most at risk and therefore most likely to benefit from clinical treatment. So we have made a lot of progress since the last time I was in Chile 10 years ago, where we were talking about doing histology to make these assessments, that we actually have the evidence and the data to say, this is how you do it non-invasively in your clinic. So you don't have to remember 10,000 different parameters, just stick to FIB4, FIB4 less than 1.3, more than 2.6, and anything in the middle. If depending on the risk factors, you decide what to do. So more than 2.6, you treat. 1.3 to 2.6, you treat based on family history and other factors that are going on. And less than 1.3, their risk is so low, basically lifestyle intervention is all they need from a liver point of view. Now, the pathophysiology of the disease involves this overload of lipids and glucose in the liver, which leads to steatosis and metabolic stress. That leads to cell injury, cell death, apoptosis, inflammation, and then fibrosis. The initial parts, the steatosis, apoptosis, and inflammation are considered parts of disease activity, and its readout or consequence is fibrosis or disease stage. Of course, this gives us different types of therapies. Now, I'll tell you that 2 approaches have been taken. First, to treat the upfront metabolic stress, or to go downstream with the anti-inflammatory, anti-fibrotic approach. I'm not really going to talk about anti-inflammatory, anti-fibrotics because they haven't really worked out. So I'm going to focus mostly on the front end, where we've already talked about how dietary fat goes through adipose tissue, and there are a number of targets. And we talked about GLP-1s, PPAR gammas like pioglitazone, FGF21, these all act over here. And then the sugars get converted in the liver through a process of de novo lipogenesis. And each and every enzyme in this pathway has been targeted for drug therapeutics. And then this leads to free fatty acids, which can get converted into triglycerides. And DGAT and PNPLA3 determine the movement between back and forth between triglyceride and free fatty acids. And that determines the export of lipids from the liver tissue. So each and every one of these has now been studied, and drugs are in various phases of development. Now, if you think about the goals of treatment, you want a good treatment to make you lose weight. improve your lipid profile, reduce MACE, stabilize GFR, improve glycemic control, and reduce progression of NASH to cirrhosis. So let's look at these different classes. So TZDs can make you gain weight, so can PPARs. And then you have essentially, a lipid profile. Occasionally, some reports have suggested TZDs can actually increase LDL cholesterol, but overall MACE seems to improve, glycemic controls improve. And certainly with lanifibranor, which is a drug which recently has been studied, heavy on PPAR gamma. This is an agent, it's a pan-PPAR agonist that actually improves both NASH resolution and fibrosis improvement. Phase 3 trials are undergoing. FXR FGF19 came with a lot of promise, but there is an issue. They do make you lose weight, but the LDL cholesterol goes up, requiring statins. We don't have data on MACE and GFR, but it does produce decrease in fibrosis. And unfortunately, FGF19 has now been stopped for development for non-cirrhotic NASH. The data for cirrhotic NASH is coming through clinical trials. FGF21 is another fibroblast growth factor that makes you lose weight, improve lipid profile. We don't have data on MACE and GFR. It's neutral with respect to glycemic control. And unfortunately, the Falcon trials, which are the best studies with histology, were completely negative. There's a small study from Akero looking at efruxifermin that was published, which is positive with respect to fibrosis and improvement in steatosis. We have to see how these different FGF21s actually behave. There are other FGF21 molecules from 89 Bio, et cetera, that are in play. Thyroxine beta receptors, very non-toxic molecules, neutral on weight, improve lipids, improve NASH resolution, but its effect on fibrosis still sort of uncertain. And we've talked about GLP-1s. So where we are in the field now is, and where we are going is initially after the initial diagnosis, we should focus on weight loss, which has been shown to improve all the end organ diseases that are associated with this condition. Use statins and with or without fibrates, depending on its need. Fibrates, particularly if triglycerides are increased. And start with a GLP-1 and SGLT2 inhibitor, especially if you have type 2 diabetes and diastolic dysfunction or chronic kidney disease. Having done this, it would be worthwhile following the patient for a period of time and reassessing. And if you have residual active disease with increased liver stiffness, that's where you need targeted therapy. And this is, I think, where the field is moving towards looking at really active NASH with F3, F4 fibrosis as the most important populations that need to be treated, with the ultimate goal of reducing mortality, healthcare cost, function, and quality of life. So I'm going to stop over here, and hopefully this gave you a paradigm for how we are increasingly seeing GLP and SGLT2s become background therapy in which the NASH develops, and how that itself may actually benefit the liver. And so you have to give it a chance to see when you're using GLP-1s and SGLT2s that whether they are working or not before you move on to more NASH targeted therapeutics. So with that, I will stop, and I thank you for your attention.